Howdy. Okay. It's my pleasure to introduce to you today my colleague and friend, Miss Kristen Hicks. Kristen began her career in nutrition at the University of Arizona, where she was awarded her bachelor's degree before completing her master's degree and dietetic internship at Texas A&M Kingsville. During her time here in College Station, Kristen has been the founder of several mentorship programs, including the RD Mentorship Program and the Aggie Graduate and Professional Community Club Mentorship Program. Kristen also serves as the current president of the Nutritional Sciences Graduate Association, as well as a practicing dietitian in both the corporate and consulting spheres. Her work as a dietitian awarded her the prestigious honor of Young Dietitian of the Year, bestowed by the Texas Academy of Nutrition and Dietetics. Her current research has resulted in 3 first author publications and a vast array of published webinars and educational media. Today, Kristen's seminar entitled The Use of Nutrition Education Courses to Increase Physician Knowledge will focus on her pursuit to close the knowledge gap between physicians and nutrition professionals by constructing nutrition-based webinars and educational courses for physicians. Please help me welcome our very own Kristen Hicks.
Thank you, Michelle, for that kind introduction. And thank you for inviting me to speak today. This is my exiting seminar, so it's very exciting. So let's go ahead and get started. So here's a brief outline of what we're going to be talking about today. I'm going to give you a little bit of background and an overview, and then we're going to talk about both phases of my dissertation work, followed by a discussion and conclusion. So why is this important? Why is my topic important, and why are we all researching nutrition? That's because there's a rising issue with health and chronic disease. So unhealthy diet contributes to over 650,000 deaths every year, and several chronic diseases are related to diet and lifestyle choices, such as inactivity. Specifically heart disease, diabetes, cancer, and obesity, which I'll talk about later in this course. So there's a rise in health and chronic disease. I took a few graphics from an online source, and they were just talking about how you can see a majority, 90% of adults consume too much sodium. There's very poor and unhealthy lifestyles. In addition, though, there's an ongoing need for awareness and early detection, and this is partly what really stems my research. So 1 in 4 individuals with diabetes go undiagnosed, and that's why I believe nutrition education is important for physicians. So these two ultimately will contribute to, this is slow, will contribute to the leading cause of death and disability. And again, a lot of the leading causes of death here in the U.S. are related to diet and lifestyle choices, and this is what we want to mitigate. At least 50% of individuals have 1 or more chronic disease. This is a huge issue. Again, why you all have jobs, why you're doing nutrition-related research. So we can mitigate this by changing lifestyle habits in addition to increasing awareness and early detection. I know this slide's quite busy, but I just want to show you that nutrition and lifestyle counseling in medicine is very effective. So lifestyle choices can account for 40% of cardiovascular deaths. When lifestyle counseling is integrated into primary care, we have seen such as like a 5 to 10% weight loss. This is reducing the incidence of type 2 diabetes. Again, this is just one study. The Chinese Diking study was a 6-year randomized control trial, and it showed that lifestyle intervention significantly reduced cardiovascular and all disease mortality. So again, the integration of lifestyle and nutrition counseling has had those positive impacts. And then related to type 2 diabetes, there's several clinical trials that talk about diet, exercise, and weight counseling to improve hemoglobin A1C, which is a blood glucose marker for diabetics. There was a 2-year trial in physician-delivered lifestyle counseling, and they showed significant weight loss as well as improved HDL and triglyceride levels. Again, this is just emphasizing that message that lifestyle counseling in practice is effective. So we know that it's effective, and we're starting to understand even more that when this lifestyle counseling includes both diet and physical activity, we're seeing an even greater impact because really they go hand in hand. So this study published in 2014, you can see up here at the, oh, I guess I can, sorry, I'm used to teaching in a classroom, so right here, this is diet and physical activity involving 12 months. So it's beneficial. You can see it's to the left showing that there is a change in weight loss. It's a positive change, so we're losing weight. But when diet and lifestyle are given for greater than 12 months, we see a long-term sustainable weight loss. You can see this is farther over to the left. Again, this is just emphasizing the impact. I want to point out one study in particular because this is very related to what my research is doing and how I structured my courses. So the title of the article was Motivational Interviewing and Dietary Counseling for Obesity in Primary Care, an RCT. And this was in pediatrics, so this is related to the pediatric population, but I will extrapolate it to my population. So there were 42 practices within this study, and the physicians, including their patients, were split up into 3 groups. Group 1 was usual care, so physicians just prescribed their usual care. Group 2, the primary care physicians received motivational interviewing training, in which they helped their patients with motivational interviewing. And Group 3, primary care and registered dietitians worked together to deliver motivational interviewing. And their primary outcome was BMI percentile at a 1 and 2 year follow-up. Now, what did they see? Groups 2 and 3 had over 65% of patients completing the motivational interviewing. And you can see that in Group 3, which is that combination of both primary care physicians and registered dietitians, you see a greater impact in weight loss. So I just pulled up 2 tables over here on the right. And so you can see in Group 3, which is here at the bottom, there was a BMI percentile difference of 4.9 comparative to Group 1, which is just usual care, indicating that there is a significant impact whenever we deliver motivational interviewing, lifestyle, and diet counseling. And then down here on the second table, again, you can see Group 1 to Group 3. And depending on the quantity of nutrition and lifestyle motivational interviewing consults, you will see a greater mean BMI percentage change. So individuals, and this would include both the parents and the children, who had greater than 8 motivational interviewing sessions, resulted in a larger mean BMI change. So really this goes to show that diet and lifestyle is effective, but inclusion of that motivational interviewing, that change, behavior change, would ultimately help to, would ultimately help to provide a more sustainable and a greater impact change. Yeah.
Can you remind me what Group 2 is?
So that's just physician-delivered motivational interviewing.
So Group 2 and 3 aren't different, is that correct? No reading there?
So
There's no difference between the 3.8 and the 4.9? And again at the bottom?
It's not significantly different. It's the significant differences between Group 1 and Group 2. There is a change. You can see 3.8 and 4.9, but that is not significant.
So do you think that having an RD, the difference is a physician versus a physician plus an RD? Is that what I'm getting correct?
Yes, ideally, if we can have physician plus registered dietitian, that would produce the ultimate, greatest impact. But just having a physician-delivered motivational interviewing is effective as well. This is really just kind of setting the stage for what I want to talk about. Yeah, good question. So again, that was kind of just setting the stage, and this will be incorporated into my final few slides. So with preventable and chronic disease on the rise, what do? Ultimately, I want to educate physicians, which then they can educate their patients. And that's really the end goal. So Healthy People 2020, this is something that they set out every 10 years. And in the Healthy People 2020, there were specific objectives to increase the proportion of physician office visits that included lifestyle counseling related to nutrition or weight. So clearly it's needed, but we're not necessarily demonstrating that in practice. So there are also two other objectives that fall underneath that I just wanted to show that there is a need for increasing physician office visits with counseling. So we see this need, but maybe this need cannot be fulfilled. And that's partially due to medical nutrition education. It has been long described that medical nutrition education is not is insufficient. And actually, according to Adams and colleagues, it's actually been declining. So I put this table on here. You can see in 2000, there were about an average hours of required nutrition education. This is a survey of all medical schools in the U.S. Had about 20 hours in 2000. You take it to 2012, and there is a slight decline of about 19 hours. So even though the National Research Council recommends 20 to 25 hours in medical school curriculum, we're not seeing that. And so this is contributing to the problem. I looked up the 2013 Accreditation Committee of Graduate Medical Education Guidelines, their program requirements, and the term nutrition, diet, and lifestyle are all completely absent. So it makes sense that we're not seeing it in the graduate curriculum because there's no real accreditation standards. And if there's no standards, why do we want to teach a part of a curriculum that's not being tested on? So the standard licensing, the USMILE, has been reported to have little to no nutrition-related questions. Again, if these physicians or medical students are not being tested on nutrition content, then why would medical school providers feel the need to include nutrition education in the curriculum? And then I included that table up there on the right. So when there is nutrition integrated into the classroom in medical school, a lot of time it's not nutrition-focused courses. It'll be nutrition integrated into biology, clinical practice, physiology. So they're not dedicated nutrition courses. They're more intertwined into the already existing curriculum. So clearly there's a disconnect. We have recommendations that physicians need to provide nutrition counseling, but they're deficient in medical nutrition education. And then on the other hand, patients are expecting physicians to deliver nutrition counseling. So physicians report nutrition counseling in less than 50% of all patients, but a lot of medical chart reviews show even less. It was observed in a one-year study that basically looked at all the online charts, is that there is less than 20% of primary care visits that include a nutrition component. A study by the American Dietetic Association, which is now the Academy of Nutrition and Dietetics, they deliver a survey to figure out where people get most of their nutrition knowledge. And 64% of Americans believe that physicians are very credible sources of nutrition information, which, according to them, maybe not so much. So I took this quote out because I really think it emphasizes what's going on. Primary care physicians surveyed often avoid nutrition counseling because of the lack in training, confidence, and proficiency in the area. And that's what we'll address in this seminar. So my research is called PNEP, Physician Nutrition Education Program, and it's a two-phase initiative. Phase one, I did a survey development and distribution, and this was to determine the current knowledge and confidence of physicians regarding nutrition and nutrition counseling. I also did this survey to determine the current methods of obtaining continuing medical education. And that leads me to phase 2, which is a webinar and course development and implementation. So I developed nutrition-focused continuing medical education, and I launched these continuing education courses on online platforms. So phase 1. My objective for phase 1 was to determine the need and interest of physicians' nutrition counseling experiences and also the continuing medical education. So our hypothesis was that we would be able to measure a difference between current confidence and counseling, with potentially the interest in improving nutrition knowledge. So we developed, distributed, and analyzed data from a survey. So what did the development look like? Our survey was developed by a combination of using 2 previously validated surveys. So by Frank and colleagues, I included the demographic and professional workplace locations. Spencer and colleagues, I included self-reported nutrition counseling behaviors and attitudes. I took these questions because these were validated surveys. And then I also included additional questions that focused on our outcome objective. So because I was creating a new survey, I wanted to make sure it was validated. So it was reviewed by a panel of experts for content validity, 2 MDs and 4 PAs. A PA is a physician assistant, so a step below an MD. So what did my survey look like? I had 7 questions on demographic and practice information, 4 questions on nutrition practices, 3 questions focused on nutrition in the practice setting, and then 6 questions, again, regarding our objectives, so looking at the methods of obtaining CMEs. And this was designed on Qualtrics, approved by the IRB, and there's just an example of what some of the questions would look like on the online survey. So what were my results? I had an N of 54. A majority of my participants had MD credentials, but then I also had a few MD, PhD, and DO. It was pretty split between male and female, 57 versus 41%. And what I liked about these survey results was that I had a broad range of both age and years as a practicing physician. So you can see 25 up to 55 and older. There's a number of participants that fall within each of those categories. And then years as a practicing physician, I think, may provide some sort of insight to where we could go with nutrition, continuing education in the future. So I do have physicians that have practiced over 10 years, but I also have some fairly new physicians. Now, with this survey, they did provide some demographics. And so you could see different areas of practice, what their specialty was. And we were expecting a majority to be in family practice, and I'll talk about why we are expecting that. But we also have physicians in emergency medicine, pediatrics, cardiology, and an array of other disciplines. So I mapped out all the zip codes where physicians are practicing, and we have a big concentration right there in the middle of Texas, but we do have some kind of all around. Not ideal. We would have liked to see physicians from across the state, but I'll talk about why some of our results look like this. Yeah.
How did you send out this survey, and how did you decide where it was going, and what was your sort of response rate?
Yeah, so I will talk about that, but it's a convenient sampling method, which I think, no. So it's a convenient sampling method. We talked to some of our colleagues who had administration with listservs, because we can't directly contact physicians ourselves, according to our IRB that we approved. So we distribute it via some of the listservs, especially like in the College of Medicine, and that's why you really see a focus in this area, because a lot of the Texas A&M College of Medicine physicians reside in Dallas and Austin. Again, it's a convenient sampling method. We distributed it via email, so there was no paper surveys. So We would have liked to see more. We tried to get our surveys spread out through Texas Medical Association, but there was a lot of pushback on that.
So you don't know a response rate then because you don't know how many people it went to?
Correct. Yeah. So what did we find out from our survey? We found out that physicians acknowledge their lack in confidence. Only 15% of our participants felt highly confident in performing nutrition counseling, which is concerning. And our low confidence levels directly are correlated with low levels of patient counseling in nutrition. So here on this graphic on the top, patients who require nutrition education, you can see that this lime green is usually or always. So 70% of patients usually require nutrition education. Now, when we're looking at how often do physicians actually provide nutrition counseling to patients, the usually or always drops to 46%. Now, one thing we didn't address was how lengthy are your talks. This initial survey was really just to get some information about is nutrition in practice, and really our goal was for the continuing medical education. So not as lengthy of a survey as we would have wished to provide. What did the practice settings look like? Quite a few physicians were unaware of nutrition services. So we're physicians in a practice that promotes nutrition awareness. A lot of physicians said no. And again, that's a very vague question, so it would be nice to have a follow-up question about that. Is there currently a registered dietitian working at your facility, hospital, or practice? So a majority did say yes, but how often would you refer patients to a registered dietitian? And either never, rarely, or sometimes was the majority. So usually, always, not really seen. And if you think back to our last slide, 70% of all their patients usually or always need some sort of nutrition counseling. So again, there's that disconnect. So what about CMEs? CMEs are continuing medical education. These are required for physicians in Texas, 48 every 2 years. So most physicians prefer enduring materials, and that would be either a webinar or a self-study. That's what's considered enduring, so 56%. But we also had some other methods of obtaining CME credits, such as an in-person course like a conference or seminar, faculty teaching, which again kind of makes sense because a majority of our physicians, we assume, we don't know, but we assume work for the College of Medicine, and then some with manuscript review. So we're going to focus on this enduring material. We asked physicians, have you ever attended a seminar, webinar, or conference about nutrition? Majority say no, but there's still 44% that have. And then we followed up with a question of, would you be interested in a webinar on research-based nutrition education? And again, a majority say yes. Now we followed up again on, would you be interested based on what's the likelihood that you would participate? And 57% said highly, even though 67% said they'd be interested. So we can see there's interest, but it would be nice to have a lot of follow-up on what exactly do they want. And then the last part of our survey was to look at the rankings of what they felt like are nutrition education topics that are more highly applicable to their scope of practice. And so you can see obesity, weight management, diabetes management, and cardiovascular nutrition were the top 3. But there were also responses in renal nutrition, cancer, nutrition through the life cycle. But we're going to focus on these top 3 because that's ultimately how we decided on our continuing education courses. There were some correlations which need to be further investigated from this survey data. So practice area expertise was correlated with how often they see patients who require nutrition education. Again, we need to delve deeper into this. Confidence was significantly correlated with how often physicians see patients who require nutrition education. and how often they talk to patients about nutrition. And we also saw a correlation between how often physicians see patients who require versus how often they perform nutrition education. So these are just kind of preliminary connections that we've started to make.
Quick question.
Yes.
In terms of the original survey, Will, do you have as a hypothesis that gender, for instance, and practice, years in practice, might be significant in terms of?
I don't, but that would be a good hypothesis to something to investigate and look further.
What did your data tell you in those cases?
Oh, sorry. Yeah, we do. There is potential that gender or years in practice would have an influence, which we can see. There's some correlations on how often they see patients depending on their practice area. So this would be something to further investigate.
And be able to explain.
And to explain. So, kind of to sum up in a discussion of phase one is that physicians have acknowledged a lack of nutrition knowledge, and it confirms the issue that has been highly addressed in the literature that there is limited medical nutrition education. But physicians are showing interest in nutrition-focused continuing medical education. And part of that, we believe, is due to little to no opportunities at state-level medical associations. But like I said, there were some limitations to my phase one. It was limited to Texas physicians, partially because it was a convenient sampling method. We only had physician addresses of Texas physicians. Ideally, we could expand this nationwide, which we attempted, but it didn't work. But that's something to go through in the future. And then our survey was voluntary with no compensation, which could have put some bias in the survey. Physicians who are more interested in nutrition could have been filling out our survey compared to their peers.
Kristen, the point that was brought up regarding the response rate is quite germane with the limitation because the key here is representativeness of the respondents.
Yeah, definitely.
Well, that was going to be my next question. Is it more likely, do you think, from your other readings that people who have a lack of nutrition knowledge would reply to a survey that said, yes, I need more nutrition? Or
Right, and they likely wouldn't, according to what's been published. Most physicians who are even going to take the time to fill out a survey would have to have some sort of interest. Now, this email was sent out by Dean Ogden within the College of Medicine, so potentially that could have swayed some of the personnel who responded to the survey. But I think there needs to be a lot of follow-up, and especially if we could see how many people really had access to the survey, how many opened it, and how many completed it. That would all be nice information to know going forward.
So how did you use that information then to interpret some of this? Because I haven't heard you, other than the limitations, I haven't heard you say how you use that to interpret anything you've presented, because that last part's really interesting. It's not just physicians in Texas, it's physicians in our system.
Right.
They're educators,
Right.
which makes them, I think, potentially a skewed audience.
Yeah, I completely agree.
And it sounds like it's their boss that sent it out to them. So I think that's even, and I understand the convenience, and you've got to get some data somehow. So I get all that.
Right.
But then as the person collecting the data, how do you then apply that information or in your interpretation? That's what I'm curious about.
Yeah, I think you bring up a great point, because I'm sure there is some bias with that. It would have been amazing to be able to have access to a physician listserv where it wouldn't have introduced bias. But this was really just a needs assessment. We wanted to kind of get some feedback on, are they getting any kind of, are they interested in nutrition education, and specifically that continuing medical education component, because our second phase was focused on continuing medical education. Now, physicians, again, there probably was some bias going forward in why they maybe selected some topics. Obviously, that's depending on their scope of practice, but it was to just gain some general knowledge, and this all is aligned with what's published in the literature. This is what we're seeing over and over. Now, some other researchers have nationwide surveys, some are local, some are statewide, and so there hasn't been any Texas-focused survey on nutrition needs.
And specifically, Clint, one way that the data was applied was related to the slide that you just showed, which webinar topics, because there's a universe of webinar topics out there that could have been selected, but Kristen let the data drive or determine which topics would be converted into her educational strategies.
Yes.
This is really interesting. I just have a question about how you interpreted some of the data that's maybe different than how I would interpret it. So you put up a pie chart that said that 48% of people sometimes refer patients to an RD,
Dietitian.
and 17% always do.
Mm-hmm.
And you had said, oh, well, the majority don't.
Right.
Whereas I might add that up to say, well, 65% say that they sometimes or they always refer, and yet 70 or 71% of their patients they thought needed referring. So to me, that sounds like if 65% of the time when a patient comes in, they sometimes or they always refer them to an RD,
Yeah.
and they think only 70%. To me, that seems really good, actually.
Yeah, definitely. I guess that is based on
So like,
interpretation.
is the glass half empty or half full? I'm not sure.
Yeah.
I just thought I'd throw that out as like a possible other interpretation.
Yeah, I think that's great because there definitely are two sides. I'm sure I probably have some potential bias myself being a registered dietitian and what I see in the clinical side. But yes, you are exactly
And I
right.
think, when you're checking boxes, if you say I sometimes do, well, that would mean like, well, not every patient that comes in needs it, so
Right.
not every time do I.
Right.
It depends on your mindset, I think.
Yeah, and again, these questions were very vague. It's extremely difficult to get physicians to fill out survey data because they're so busy. So we wanted to make our survey as basic and easy as possible to answer a few questions of how we wanted to address phase 2. That was really our main goal for phase 1.
How do you know physicians are so busy?
How do I look in the literature? It's
Do
widespread.
they show the number of hours they work in a day?
No, I've never actually.
Why are you assuming that they're so busy?
Because they have less than 12 minutes per each patient consult, and usually it's back to back to back to back all day.
So that is a institutional bias placed on them.
Correct.
Do they have 7 to midnight every evening? Do they? I know in residency they have, they're preoccupied with
Right.
slave labor. But when they emerge from that, what is all these physicians? How much time do they have? You're assuming they're so busy they can't respond to there's no room for new scholarship. They can't respond to anything. They are working around the clock, and I'd just like to know based on
Kristen,
what.
you had insight from Dr. Fury.
Yes. I for second phase, we're getting ahead of topic, but for second phase, I did work with a physician, so I do have some insight. In addition, I've worked as a dietitian for 4 years, so I've seen the ins and outs of clinical practice. I know they're busy. You look in the research, and there's not a lot of survey research with physicians because one of the limitations is time, trying to get participants to respond when they're practicing physician. Just like a researcher, you have, not only your workload, but you have family life, professional development, and so that all would contribute to lack of time.
Well, maybe at the end I can ask you some questions about the overall structure of their entire profession, why it's misguided, and how it needs to change. That's a much broader question, because you're trying to force nutrition into a very regimented portfolio.
Correct.
That actually is doomed to fail.
I hope not.
Well, it will. It is failing right now.
Right.
It's unsustainable. They can't generate enough money the way they work. They're not delivering on levels that support the patient's real needs. And so they're making money for people, but they're not really improving the quality of life for many of their subjects, many of their patients. That has to change fundamentally.
Right, but if you go back to the kind of background discussion, when lifestyle and nutrition is integrated into primary care, you are seeing clinical improvements.
Oh, yeah.
And when you have clinical improvements, ultimately you're cutting down physician workload, readmits, and so all of that is going to ease up the schedule of a physician.
Right, but that doesn't matter in the bottom run because they're there to make money And the more hits they get in the clinic, the more money they make.
Correct.
It's as simple as that.
Yeah, you're
So
right.
there's an economic incentive that's counterintuitive. Everything you say.
I think with the
busier
old
the
healthcare
physician,
guidelines.
The more money they make. The sicker the population, the more money they make.
Correct.
If they don't make it, their medical group makes.
I don't think we're gonna solve the entire medical industry at this point, so.
No,
I
but
mean,
it's important to be cognizant of
Definitely.
what you face
Yeah.
in terms of why they're not capable of taking in more nutrition knowledge.
I
Saturated.
completely understand. Well, how about we move on to phase 2, and then hopefully I can address some of those questions at the end. So we do have 2 publications based on phase 1 of our physician nutrition education project that I wanted to highlight. So let's move on to phase 2. You are correct in the sense that there is issues with integrating nutrition into counseling practices. So phase 2 objective was to determine the improvement of knowledge as quantified by changes in pre versus post tests that are associated with this continuing medical education course. And our hypothesis says that we think that there will be improvements between these pre and post test scores, which I'll address within this part of the talk. And we will analyze the data by comparing 2 10-question tests. So I collaborated with a local physician, Dr. Morgan Irion. She's a family medicine physician, used to be with the Physician Network in the Bryan College Station area, but she has now moved to the Physician Network of Indiana. And so our course topics were chosen based on survey data, as you recall, type 2 diabetes, weight management, and heart-healthy cardiovascular nutrition. So what are my courses? My courses are either a 45 to 50 minute or 55 minute webinar or an 8 to 12 page self-study. Again, both of those are classified as enduring materials. These are each accompanied by a 10 to 20 question pre and post test, and this is a question bank. And then there is also a course evaluation required. This data we do not receive, and I'll talk about why we don't receive this information. So how did I develop my courses? I first developed an outline of a highlighted importance, and this talked a lot about the basics of nutrition education with that specific chronic disease, whether it be type 2 diabetes, obesity, or weight management. And I talked about some of the recommendations given at the national level. I then started to build in case studies, so you can see this quick example over here. This is from my self-study. It's just a very basic case study to get physicians thinking about including some of this content into practice, and also active participation, which we know according to the research helps to improve learning. I accentuated the frames model, which I'll talk about and what that is. I then talked about how to actually incorporate nutrition with patients. Now, I'm not expecting to get a 15 to 30 minute nutrition counseling session. That's not my objective through these courses. It's just to introduce the topic, and that's what the physicians learn when they take our courses. And then I talk about how to emphasize the healthcare team, because this is where healthcare is transitioning. So before, physicians were not able to bill for nutrition services, but now, according to the new Medicare, we can start billing, physicians can start billing for nutrition services. So I did cover some billing and payment reimbursement and finished with a summary. So this is that frames model that I was talking about by Miller and Sanchez, and it's a motivational interviewing model. It's a collaborative, goal-oriented style, and the reason why I included this, go back to that pediatric study that I talked about in the beginning. Motivational interviewing has been successful in practice, whether it be a physician, a dietitian, a therapist, and so I included this in each course. And the strategy is to make change statements, so avoiding judgment, confrontation, and unwelcome advice, which is seen in the literature that physicians a lot of times do have judgment when their patients have certain chronic diseases. So this is the step that I go through each step individually on how a physician could integrate motivational interviewing in practice. Now, where did we launch our courses? Our courses, we partnered with the Texas Medical Association and the Texas A&M College of Medicine. These courses were accredited for one continuing education credit, so either an AMA PRA Category 1 credit or an ethics credit. At TMA, these courses cost $29 for any Texas members or $79 for an outside member. At the College of Medicine, there's no fee associated. So physicians who are taking these courses will have nutrition interests. I just want to address that because they are paying for it. But these are accredited, so these can be a part of their 48 biannual requirements. So our course 1 is type 2 diabetes. This is what our course would look like. The first slide on the webinar version, or the first kind of real parts to the self-study. And this was launched January 1 of 2016. And why is diabetes important? 1 in every 3 people will develop diabetes in their lifetime. So clearly it's a concern. There's over $245 billion that cost our U.S. healthcare system because of diabetes. And it's expected, and it already has, quadrupled the amount of Americans with diabetes from 1980 to 2012. So a clear concern with this chronic disease. What are some contributors to diabetes? Well, diabetes is partially having an issue because overweight individuals have excess weight, which ultimately can contribute to insulin resistance, which a lot of you know because that's your research. It's contributed to sedentary lifestyle, poor dietary factors, and there is a genetics component. And so there are national recommendations, the U.S. Preventive Services Task Force. And so there's different recommendations depending on each of the chronic disease that I'll be talking about. So abnormal glucose patients should receive intensive behavioral counseling interventions. So these are national recommendations, but yet we're not seeing it in practice. So phase 1, course 1, some of the data collections. So like I said, we have a question bank, and this question bank was 16 questions that are related to the content of the webinar, and a webinar or self-study, sorry. And randomly 10 questions will be chosen for pre and post test. We then collect some demographic data. We collect their credentials, gender, specialty, years in practice, and location of practice. Keep in mind, all of this is at the Texas Medical Association, so we don't get this information directly as part of our collaboration efforts. So at course 1 outline, this is what it would look like. Review of health consequences. What are the recommendations? What's the role of the physician? What do they need to do? We talk about medical nutrition therapy, figure out how to educate patients, some of the best practice techniques. And the best practice techniques is because this is also an ethics credit. And then we talked about billing resources and just some standard resources for both the physician and the patients. So we've had 43 participants pay for the course. That's 24 males, 19 females. A majority have MD credentials, but some also with DO. You can see on the top right, those are the different areas of practice, and this is all what physicians would submit when they register for the course. And you can see a majority are either in family medicine and internal medicine. It makes sense because those are the physicians that are more likely to discuss nutrition-related concepts, but you also see dermatology, anesthesiology, surgery. So we are getting to an array of physicians. And then at the bottom right is the years in practice. So we have fairly new physicians taking our courses up to 57 years, with the average about 20 years. And this is good because some research shows that the older physicians aren't interested in nutrition education. They're kind of set in their ways. And the new physicians are maybe a little bit more inclined to do this. So this is nice seeing this kind of data. So we have 5 states represented by our participants, but a majority reside in Texas, which we would expect because this is launched at Texas Medical Association. But any Texas physician or any physician can access the course. It's just quite a bit more expensive to get a hold of the course. So we have physicians in Wisconsin, Missouri, Alabama, all over the map. So what are our outcomes? I told you we have 43 who have enrolled or paid, but when we receive the data, it's only for those who completed the course in its entirety. That would be a pre-test, taking the course, a post-test, and a post-evaluation. If they don't complete that, then we don't get the data yet. So they have to complete the course in its entirety. And so we only have 31 at this point that have done that. 93% of participants have increased their scores between the pre and post-test. So the pre-test is given before they take the course. Post-test is given after they take the course. The pre-test average is 5 and the post-test average is 8. So there's a significant improvement based on a paired t-test between pre and post scores. And you have to have 7 or more to consider to pass the course for the CME credit, which we had 93%. That moves me on to the course number 2, which the topic is weight management. And so again, this is what the course would look like if you were to see the first slide of the webinar or the self-study. And this was launched June 15 of 2016. Now, why is obesity important? As you all know, obesity is growing here in the U.S. More than a third of U.S. adults are considered to be obese. No state has obesity prevalence less than 20%, as you can see in this map, which is a big jump from 1990. So clearly this is a concern. Obesity-related conditions are some of the leading causes of death, which again is why we want to integrate this nutrition counseling into practice. And this isn't just happening here in the U.S. This is happening worldwide. What are some contributors? It's an increase in sedentary behavior. People aren't active anymore. They're sitting at a work desk all day. They go home and watch TV. And again, that's a generalization, but this is what we're seeing here in the U.S. There's an increased amount of screen time, increase in portion sizes and frequency, and a lack of knowledge on how they should make healthy eating and lifestyle choices. So the USPSTF, which I talked about before, they recommend that there should be screening for all individuals for obesity, which is often always done in healthcare anyways. And then patients who have a BMI greater than 30, which would be the obese category, should be referred to intensive multi-component behavioral intervention. And this was a grade B, but it's currently being updated, and there's talk that it's going to be moved to a grade A, meaning most significant. We have enough research background to support this. So phase 2 looks very similar. We have the question bank. We collected the same demographic data, and our course 2 outline looks very similar to the type 2 diabetes. We kept consistent between each of these courses. So what does our outcomes look like so far? We've had 35 physicians who have both enrolled and completely completed. 20 males, 15 females. Again, you see this majority MD, but we also have several other credentials. So dentistry over there is that DDS, a PA, physician assistant, DO. We have an array of practice areas. Again, this is good news, especially for someone like me. This is great knowing that physicians are interested, and it doesn't mean they're just in family or internal medicine. So you see psychiatry, endocrinology, surgery. And then we have a range in practice years, so 3 to 38 years, again with the average of 20 years. And this is good. We're seeing all sorts of individuals taking these courses. We only have 3 states represented here, so again, majority of participants in Texas, which we would expect because it's at the Texas Medical Association. Sorry, I'm kind of going quickly, we're running out of time. So we've had 35 who've enrolled and completed. 97% of our participants had increased scores between pre and post-test. Now, for some reason, Texas Medical Association, which I brought it to their attention, they are giving all 16 questions for this CME, not the 10 randomized. I'm not sure why that's happening. I think it's a glitch in their system. So they're trying to work that out. So 100% had passing scores of 13 or more. The pretest was 11 correct. The post-test on average was 16, which is good. And the paired t-test, we can see a positive increase in knowledge. So it is significant. And moving on to course 3, which is heart health or heart disease and cardiovascular disease. This is what the course would look like, and this was launched January 31st of 2017. Heart disease is the #1 cause of death, big concern, and that's why we want nutrition and lifestyle to be integrated into practice. About 787,000 people die from heart disease, stroke, or other cardiovascular complications. Again, a big concern. Now, there's quite a few contributors, and especially diet. According to the American Heart Association, less than 1% of adults here in the U.S. meet an ideal healthy diet. So that's about reducing refined grains and sodium. Nearly 1 in 3 Americans have no regular physical activity. People still smoke, they're overweight and obese, so all of these are ultimately contributing to heart disease. So what are the USPSTF recommendations? To offer or refer adults who are overweight and obese who have additional cardiovascular risk factors this intensive behavioral counseling intervention. And the USPSTF describes this multi-component as use of the healthcare team, which again, I kind of talked about what's something that we want to do. And then currently this is under review about the healthful diet and physical activity guidelines for cardiovascular prevention. So both of these, the first one is a grade B, but this is a grade C. So we'll see if that moves up to potentially grade A or grade B. Now, our course looks very similar. There's a question bank of 15 questions, and then randomly 10 questions will be chosen. We're collecting the same demographic data, and our outline looks very similar. Now, we don't have any data for that course yet, although you can see this is what would look like whenever you go to Texas Medical Association and type in nutrition. You can see all of our 3 courses. And down on the bottom right, you can see there have been 6 physicians that have completed this 3rd course, but we haven't gotten that data yet. We usually get it about every 2 to 3 months because it takes a while for them to go into their system and update us. So let's finish with some discussion. This survey, we believe, was successful in confirming physicians' limited nutrition knowledge and current interest in participating in nutrition-focused CMEs. We believe that online CME courses launched at the state-level medical association is effective to increase nutrition-related knowledge. And we believe that varied physician specialties, because they enrolled and completed our courses, we think that this could indicate that several practice focus would be interested in learning this nutrition knowledge. These courses are filling a need ultimately that physicians have regarding nutrition content. So in conclusion, we've addressed that there's low levels of nutrition counseling by primary care providers. We've addressed the fact that there's limited opportunities in nutrition-focused courses. We have used the technology, using the online technology to deliver CMEs. And then we've collaborated with TMA to ultimately expand the reach of physicians. Now, this would then go to our final goal was to improve the health of Americans by integrating nutrition counseling and motivational interviewing to every physician-patient interaction. This is the long-term goal. Obviously, we are looking more at the course implementation, and so we haven't done like a follow-up. That's not part of my research, but it would be good to have a follow-up of if they've taken the course, are they integrating these concepts into practice? And that's something that we don't address. So what's next? Here we started in Texas, but we will expand throughout the country. That is the ultimate goal, to provide new CME courses for health professionals. That's our long-term goal. So I would like to thank several people. Dr. Murano first is my chair, a big supporter. Dr. Chu, Dr. Morgan Irion, the physician I collaborated with. Cheryl and Casey within the Texas Medical Association, that's who I worked very closely with. Within the College of Medicine, I would like to thank Dean Ogden for all of his support. And then Stephanie Staggs, that's who I've worked with. And I didn't address it too much in this talk, but we have all of our courses launched within the Texas A&M College of Medicine Education Library. My committee members, Dr. Adam Berry, Dr. McIntosh, and Dr. Andine. And then my research was in support with the Jane Elizabeth Watkins Cohen Endowed Scholarship. So I can take any questions. 2 minutes.
I was curious about, I really like the job that you have done so far. I think it's really hard to get physicians to do things for you, especially when it's just asking things around. I'm really curious. I actually just Google around because in Mexico the situation is different because they're forced to do it, but whatever. So I was checking and I noticed that there are already curricula for physicians about nutrition, and sometimes they're free or on internet, online. And maybe you were expecting this question, but what are the strengths or your curriculum?
Yeah, you bring up a good point. There are starting to become some nutrition education courses that are available, but those are often site-specific. So like the University of North Carolina, Chapel Hill, they have a nutrition and medicine continuing education platform. What sets our research apart is that we're launching at the state-level medical association. Any physician who resides in Texas must be a member of the state-level medical association. So ideally, they will have an ease of access through them. They get regular newsletters, and that's where we wanted to address. And that's what makes it different than what's currently available. They're private funded programs, separate websites, and a physician must know of these private websites to go on them and take the courses. And because nutrition isn't a big focal point, we thought that being at the state level medical association, we would have a greater visibility.
Yeah, because I was checking the American Society of Nutrition, I said they offer that.
Yeah.
I don't know if it's free or not, but.
And a lot of them aren't free. I know that the Nutrition and Medicine Project over at Chapel Hill, they have some free and some paid courses. But again, we're trying to address more as the state level concern. But yeah, being.
I could add really quickly.
Yep.
I know the time is brief. When we canvassed the continuing medical education offerings, hundreds and hundreds of them, there were almost none in the nutrition area. So it seemed like an incredible opportunity through an official mechanism to reach out to physicians with this type of information. And I think that's one of the strong suits of Kristen's approach, the innovation.
Yeah.
Have you thought about approaching the health insurers of the state of Texas?
That's a great question. No, actually, I haven't
They-
gone that route. A lot of insurance companies don't cover all these nutrition services. They're just starting to cover preventive medicine.
Exactly. They're under great pressure now. They have to
Very
make
much.
profit, and they need healthy people to
Yeah.
make profit.
Correct.
Okay? So it's in their interest to embrace you, or at least your long-term goal, because if you help keep people healthier, they make more money. It's as simple as that. So they are motivated to make sure physicians are practicing this kind of
Yeah.
intervention, because again, if these patients don't come back, or it takes them longer to come back, their profit margin is up. So they are an untapped entity in all of this, and they have enormous political power as well, and can tip the balance in favor of nutrition, not because they're altruists and they want to help,
Right.
because they want to make more profit. So I am always amazed that they're not at the table and part of these discussions, because they must be aware of the fact that the data you pointed out, that nutrition, if properly administered, will keep subjects healthier for longer periods of time.
Yeah, I think you bring up a great point. That is definitely something I want to look into.
Test to physicians, they cover the whole fee.
Right.
I mean,
Yeah, that'd be great.
So is there anything unique, or I guess you didn't speak much about the curricula itself. Like,
Right.
how did you determine, I mean, outside of the fact that they're trained MDs, some of them were trained many years ago, how did you determine level of curricula? And is there anything unique about the curricula? What was the process for that?
Yeah, again, great question. So I did work directly with Dr. Morgan Irion, so she gave me a lot of feedback as to what's really important, what do we need to get down to, and we didn't really cover a lot of, pathophysiology about the disease. We more talked about what are the basics, for instance, diabetes. What should they be screening for? What should they be looking for? And if the patient meets some of those triggers, then how should they begin intervention? So what are some basic nutrition interventions that they could discuss? And then what makes our curriculum very unique is that we talked about collaborative healthcare. Because again, that's where healthcare is really transitioning to, and that's how physicians will start to get compensated even more when they're working as a collaborative team. And so we talked about, what does a dietitian do? How can it benefit your practice? What's the research support of that? And then those billing codes. So physicians may say, I don't even know how to bill, especially since they implemented ICD-10, a brand new billing system. And so I talked about all the ICD-10 codes that could be related and how they could bill for their services.
So I guess my fundamental question then would be, sort of what is the general hypothesis here then? Because in the end, is it that last part about educating them about the team and this, that? Because I mean, RDs tend to be ferociously, really holding on to what they are supposed to do. And it looks like that research that Aaron pointed out, Dr. Giles pointed out early on, suggested that referring a patient to an RD is the most effective way to have an outcome. So I guess my question to you is fundamentally, what is the hypothesis and goal here? Because it sounds, from that it could be argued, what they really need to know is send them to an RD, like you would send them to a physical therapist, or you would send them to a professional. So how do RDs receive this, and then what is the goal, and how do RDs receive it if you're going to train the physician to do the counseling portion?
So our goal of our courses is not to train the physician for in-depth counseling. As you saw from the USPSTF recommendations, they need this multi-component intervention. And this is long-term. This isn't 1 5-minute training session. Our goal of our courses is to just put an idea in their head, just to mention it, because research shows if they just mention diet or lifestyle, their physician or their patients have changes in metabolic profiles, labs, so on and so forth. And so we're not trying to get them to do a 15-minute consult. We just want them to briefly mention, and then we want them to work with their team. We don't expect a physician is going to be proficient about nutrition. And so we just cover the basic concepts. What should you know? What should you be aware of? What are some symptoms, triggers? And how could you begin to provide a nutrition intervention? So again, it is very basic. Yeah.
I don't know whether you have went to the endocrine society meeting, probably you did, but endocrine society always have the CME credit in parallel with the scientific implementation. And the meeting usually have MDs and most of them are endocrinologists, around 15,000 to 20,000 at a time, every year. I thought if you kind of pitch to endocrine society like you present your program, would that help you to reaching sort of more nationwide? Because especially you give CME credit, and they're interested to take, especially some of the physician practicing in the rural area, they're desperate for something online they can use.
Yeah, I think that's great. And we do have these online courses because it's very versatile. You can access it from your home computer, work computer. But we're presenting a 1-hour course at the Texas Medical Association annual conference in May. So we're presenting our type 2 diabetes course live in person. And that will be a 1 CME credit as well.
I can tell you, endocrine society is very nurturing for the students
Yes.
and fellows. So pitch to them.
Yeah, great feedback.
Provide you.
Thank you. any other questions? I know we're a little over time. Okay.
All right, well, thanks for everybody's attendance, and again, join me in thanking Kristen. Sorry, I didn't get that out.
Thank you.